I'm Ira Kurtz, Chief of Nephrology in the Division of Nephrology at UCLA. And the purpose of these talks is threefold. The first is to improve your knowledge and understanding of how the kidney works. Secondly, to review some of the diseases that affect the kidney. And finally, to help you understand the tests that you can do to check your own kidney function. I'm going to take questions at the end of the talk, but right now we'll start with just reviewing where the kidneys are, what they do, and how they function in your body. So this slide shows the abdomen of the body, and the kidneys are seen here. They're more towards the back of the body. You can't really tell from this picture. They don't weigh much. They each weigh about 1/3 of a pound. Now, this slide shows that kidney function is not constant with age. As you age, your kidney function declines. This is not a disease process. This occurs in normal people, and it tends to be slightly different in men and women. The blue curves here in the center is the average. The upper and lower dotted curves is the range of change. So you can see that at age 50, you have, let's say, 100% of kidney function. So between 0 and 50, it stays about the same. But after age 50, and again, these are normal people without kidney disease, your kidney function declines, such that by the mid-90s, you have approximately 60% of your original kidney function. Now, doctors make the mistake of calling this CKD, or which means chronic kidney disease. Most doctors don't realize that decreased renal function in your 80s and 90s represents normality. And so you have to know what the normal function is in the elderly, because only then will you understand whether the kidney function is below normality or not. So for instance, if you have someone who's 80 and the kidney function, let's say around 70-75% of normal, that's your normal level. If it's below that, then you call that a disease. So this graph and these kind of charts are not readily available to most doctors. And so it's just something that you have to address when you see the doctor and he tells you your kidney function is abnormal and you have a problem. You may have no problem at all. So you have to know what the normal is for each age group. And the reason for the red and the blue, as I was alluding to, is that men and women tend to decline differently. In this particular study, the women were declining at a slightly greater rate than the men. And there are a number of studies showing this kind of phenomenology, and they vary. But what is true is that kidney function does not stay at your original function that you had between the age of 0 and 50. Now, if you do have a true problem with the kidneys or a disease process, we stage the abnormality. And there's 4 or 5 numbers here, 1, 2, 3, 4, 5.
I cannot hear anything.
These are called CKD stages. So there's CKD 1, 2, 3, 4, and 5. 5 is the worst. 1 is the best to have. It's best that you have no CKD stages. So if you were 100%, you would not have CKD at all. But when the renal function gets to less than 90%, if it's close to that, let's say it's 84, 85, 86%, that's CKD stage 1. And it gets worse and worse as the stages go from 1 to 5, such that at CKD stage 5, your kidney function is under 15%.
I want to see what's going on, why I cannot.
Now, these CKD stages don't necessarily progress one into the other. This is something the nephrologist watches when they're seeing you in the clinic. So if, let's say, you come in and you have CKD stage 3, the nephrologist will want to see you more often to make sure that your kidney function doesn't continue to decline such that it goes below 15. Because once it goes below 15, you really need what we call renal replacement therapy. That means you need something from the doctor to replace the function of your kidneys, either dialysis or a kidney transplant. But you're not able to function or do well once your kidney function gets to less than 15% of normal. Now, this function represents the function of both kidneys. This isn't the function of one kidney. It means that both kidneys together are giving you less than 15. Both kidneys together at CKD1 are giving you about 90% of normal. You can imagine if you just suddenly take out one kidney, you'll have 50% of your kidney function. So you'll be CKD stage 3. Let's say you were a kidney donor and you were donating a kidney to somebody. Well, you're suddenly going to have a loss of one kidney. So you'll immediately go to CKD stage 3. Now, what happens is, we'll talk about that a little bit later, potentially. When you donate a kidney, immediately you go to CKD stage 3, where you have half your kidney function. But if you're well and you're doing well and your kidneys are doing well, the remaining kidney will actually start to grow. And it will actually grow to the point where your kidney function can return not completely to normal, but maybe get you to CKD stage 2, where you'll have 80% or 85% of normality. So a kidney donor doesn't stay at CKD stage 3. The remaining kidney recognizes that there's been a loss of kidney function, and actually the tissue compensates by the remaining kidney getting bigger and bigger. It's a fascinating process in and of itself, which we won't talk about tonight. So when you get your kidney function assessed by the doctor will give you the lab report back and tell you whether you have CKD stage 1 to 5 or you don't at all. It's just something to watch. Now, the kidney, how does the kidney work? The kidney is made up of a number of structures called nephrons, and there's about 1 million of these in each kidney. You can't see them with your eye. You have to look under the microscope. And this complicated slide shows the major components of the nephron. And this is just one. As I say, there's 1 million in each kidney. You can think of these as little filtering units. The beginning of this nephron has what's called a glomerulus. You can think of it as like a filter in your bathtub or when you filter water. That's what this essentially does. The rest of this you can think of as a pipe. And obviously it's much smaller than any pipe you've ever seen, but it's lined by different cells that change the fluid inside the pipe. So there's cells that take up sugar, there's cells that take up salt, there's cells that take up phosphorus and other things, such that the final component of the fluid in the pipe is what we call the final urine. Now, this is only one out of 1 million, so all these are actually joining up within the kidney to make the final urine. And we'll talk about the chemistry of what's in the final urine. And you can actually think of this device, or what we call a nephron, as a system that keeps the chemistry of your blood in what it should be. People tend to think of the kidney as just getting rid of water, but the kidney actually gets rid of thousands of chemicals, such that every day your blood chemistry is kept constant. Because remember, every 3 times a day you're eating, and all the chemicals in your blood are getting into your bloodstream and changing the chemical composition of your blood. And it's the function of the kidney to recognize all the changes in the blood chemistry and change the composition of the solution within the nephron, such that when you urinate, you're actually excreting chemicals that have accumulated in your blood to keep the blood chemistry constant. And the problem with having CKD is, as the kidney starts getting more and more damaged, the nephron has less and less ability to get rid of the chemicals that it needs to keep the blood chemistry constant. And we'll talk about some of those functions now. So the key idea is the kidney has multiple functions. It just doesn't, getting rid of water is only one of its thousands of functions that it has to do daily. So let's talk about one of them. The kidney gets rid of something called potassium. Potassium is a chemical that's in your blood. I show bananas here because there's a lot of potassium in bananas. And the reason the kidney has to get rid of potassium is because potassium is very important for your heart function, and not just your heart function, but all the cells in your body, for the reason that potassium determines the electricity that's in all the cells of our body. All the cells of our body have what we call a voltage. And this voltage is in part determined by the potassium concentration outside the cells. And people who don't have good kidney function, the potassium in their blood starts to go up. And the doctor can measure this, and routinely this is measured whenever you have your blood tested. Potassium is usually one of the most common things that are measured. And if the potassium gets too high, that can significantly affect the electricity in your heart. In fact, it can stop your heart. That's one of the ways people are put to death on death row. They infuse potassium into the blood, and potassium will stop your heart because it stops the electricity. So it's very important for potassium to be gotten rid of by the kidney. So when you go home tonight and you eat bananas, you're actually infusing potassium into your bloodstream, and the kidney will recognize this and put the appropriate amount of potassium into your urine so that your blood potassium doesn't change. So this is a very important function. And when the kidney does decline in its functionality, the potassium starts going up in the blood. And in fact, someone who doesn't have any kidney function, for instance, someone who's on dialysis, we remove the potassium from their blood that came in from their diet artificially when they're being dialyzed. What else does the kidney do? The kidney gets rid of something called nitrogen, and nitrogen is in all the protein that you eat, whether it's meat or fish, doesn't matter what kind of meat. It can be pork, beef, chicken, turkey, it doesn't matter. Or it can be fish, it can be egg white, it can be yogurt, it can be soy. There's many sources of protein, and all protein has nitrogen in it. And the kidney needs to get rid of that nitrogen to prevent a lot of nitrogenous chemicals from building up in your blood that can affect you and affect your health. So the kidney gets rid of the nitrogen, and it's in a chemical called urea. You might have heard of that. The kidney gets rid of a certain amount of urea every day. So whenever you take in more nitrogen, the liver is actually the organ that makes the urea. The liver takes all that nitrogen and turns it into urea, puts it into the bloodstream, and the kidney then gets rid of the urea. And as you can imagine, as your kidney function declines, the urea in the blood starts building up. And it's again another chemical that the doctors measure when you get your blood tested. They measure your blood urea nitrogen, it's called, or BUN. And as the kidney function declines, your blood urea nitrogen level increases and increases. The kidney also controls your blood pressure, because not only does it get rid of nitrogen and potassium, it also gets rid of the appropriate amount of salt and water. Today, when you drink your 8 glasses of water or 20 glasses of water or 1 glass of water, it doesn't matter. The kidney will recognize how much water you put into your body and will excrete that amount of water. The same amount of water you put in, the kidney will get rid of approximately. And the reason for that is to prevent the amount of water in your body from building up. Because as the amount of water in your body builds up, many things can happen. And one of those many things is that your blood pressure goes up. You can imagine you have a certain amount of water in your blood vessels. And if you put more water into your blood vessels, the pressure will go up unless something else happens. And so the amount of water in your body is very important determinant of what your blood pressure is. And the reason for caring about what your blood pressure is because blood pressure can affect organs if it gets too high. If you have a high blood pressure, you have a greater chance of having a stroke. If you have a high blood pressure, it affects how your heart functions. And there's evidence that it can affect kidney function also. So maintaining your blood pressure within the normal range is very important. Now, how does salt affect your blood pressure? Well, the reason salt affects your blood pressure, remember salt is sodium chloride as far as the chemistry of it. Salt makes you retain water. So if you have more salt in your body, you're going to have more water in your body, and it's the excessive water again that will raise your blood pressure. So you can have more water in your body just because you're drinking more water, or you can have more water in your body because you're taking in too much salt and you're retaining water. It's harder for the kidney to get rid of the water when you're taking in more salt that the kidney's not getting rid of. If you take in the salt and the water and the kidney can get rid of the salt and the water, you don't have a problem. But if you take in more salt than your kidney can get rid of, you tend to retain more water. Or if you take in more water itself that your kidney can get rid of, again, you'll retain water. But it's this excess water in the blood vessels that makes the pressure go up. Now, if you do a study of how many Americans have high blood pressure, well, your first question is, how do you define high blood pressure? Because that will determine how many people have it. And that changes every few years, but it's currently accepted that if your blood pressure is over 100, greater than 130 over 80, you have high blood pressure. Now, there's two numbers there because they represent two different things. When the heart beats, the pressure goes up to 130, but after the beat, it drops again to, let's say, 80. Or if your pressure's, let's say, 100 over 50. When the heart is beating, right during the beat, the pressure will go up to 100, but right after that beat has occurred, it'll drop down to 50. So we look at these two numbers, during the beat and after the beat. And the reason we care about that is because either can be elevated. And people who aren't familiar with blood pressure tend to just pick one number, usually the high number, and they ignore the lower number. But you can have a high pressure after the beat, so the low number is high, or you can have a high pressure during the beat, so the high number is high, or you can have both numbers high because it's high during the beat and it's high after the beat. But the bottom line is you need to know both. And the reason, again, for caring about it, even though you don't feel anything, I mean, that's another reason people don't care about it. You don't feel anything any different than normal, usually when you have a high blood pressure, is because it can affect in the long term your brain, give you greater chance of getting a stroke, affect your heart, greater chance of having the heart not pump normally, and it affects other organs too, sometimes like the kidney. Now, the other thing to know about blood pressure is it's like the weather. It's not constant. If I measure my blood pressure now, I may get a very different reading than 2 hours from now, or the middle of the night, or the morning. And so when we say someone has high blood pressure, we're not saying it's all the time. It may be at a certain time of the day, or it may be all the time, or it may be part of the day. But the bottom line is you have to know the sort of time course of, or what we call diurnal variation of what your blood pressure is doing throughout the day. Some people have a high blood pressure first thing in the morning and it's fine the rest of the day. Some people have a high pressure at night. Some people have a high pressure all day. People tend not to measure it at night. So we don't have a lot of information usually at night unless we get a special monitor that will monitor the blood pressures throughout the 24-hour period. But when you get a blood pressure cuff, it's important not just to get one measurement every 4 weeks like most people. You have to get it throughout the day for a number of days, and then you keep the record in a notebook or in an Excel sheet or however you want. But when you go to the doctor, you should be bringing in the measurements that you've taken since the last time you saw the doctor, and preferably as often as possible, so that the doctor gets a very good record of what's going on. When we're treating high blood pressure, we tend to ignore what pressure we measured in the office, because patients, when they come into the office, always are afraid, and we get what's called white coat syndrome, where your blood pressure is higher in the office than it is at home. We want to know what it is at home when you're more relaxed. So it's important that you get a good blood pressure cuff, because many of them aren't good. To know that it's good, you need to bring your cuff into the doctor's office and make sure they get the same pressure with your cuff as they do with your machine. And even if it did work out okay, you still need to check your cuff again every 5-6 months to make sure that you're getting reliable pressures. The other thing to note is that the blood pressure is not only different throughout the day, it's also different when you lie down, sit, or stand. So it's important when you're recording your pressures at home to always do it the same way. If you like doing it sitting, always do it sitting. If you like doing it lying down, always do it lying down. But don't flip from sitting to lying, because that's going to make more noise in the measurements. Always get the measurement the same way. Most people don't get their blood pressure standing, so that's not an issue. Although there are some patients that we ask them to do it lying and standing because they have a more exaggerated fall in blood pressure when they stand up. As far as the magnitudes, the blood pressure is highest when you're lying. This is normal people now. It drops a little bit when you sit, and it drops even more when you stand. But there's certain patients who have different disorders where when they go from lying to standing, they get a big fall in their blood pressure, and that's when they feel like fainting. Now, the other thing to note is that the feeling of fainting is a very good sign of what your blood pressure is. So, for instance, we may have a person in their 80s, we put them on a blood pressure pill, and things don't get fine-tuned immediately. And they note that when they stand up, they get sudden dizziness, and that usually means that the blood pressure is falling too much. We tell them to sit down. The trick is to not get up too quickly. The other subtlety is the pills. The pills don't last the whole day. So let's say, and they don't start working right away. So let's say someone has high blood pressure in the morning. Well, let's say you're on a pill that lasts about 10, 12 hours. Well, you don't want to take that pill in the morning because it's not going to be working till the next morning, and it takes about an hour or two to start working. Pills don't work right away. So let's say someone has morning high blood pressure, we'll tend to give the patient the pill in the evening, and that will then cover the morning more accurately than it would had we given it the day before. Whereas if someone has high blood pressure in the evenings only, we'll tend to give them the pill in the mid-morning or so that the pressure will be covered in the evening. So it really depends when your blood pressure is high and when it's normal, so that we can advise you as to when you should be taking your pills. So blood pressure has a lot of subtleties that you have to be aware of. The most important problem we have is that it doesn't cause any sensations, and people don't like to measure their blood pressure. They ignore measuring their blood pressure, and oftentimes they don't take their pills. So it's just something that's difficult to treat, and younger people tend to not want to deal with it altogether. But everybody should know what their blood pressure is. Even if you feel fine and you're 20 years old, you should get your blood pressure measured just to know that you don't have a problem, because otherwise you'll never know. You don't feel anything. Okay, what else does the kidney do? Well, the kidney prevents anemia. This is something, it doesn't have to do with the creation of urine, but the kidney is responsible for the prevention of becoming anemic. Now, what is anemia? Anemia refers to red blood cells in your blood, the number that you have, how much hemoglobin, which is the chemical that's in the red cells that you have. It's important not to become anemic because red cells are important. Their function is to take oxygen that came in from your lungs to all the cells in your body. The oxygen sits inside the red cell, and the red cell takes it then to all your tissues. That's how your brain functions, your heart functions, everything needs oxygen. Well, the oxygen doesn't go into the liquid part of the blood very efficiently, but it binds to these things called red blood cells, and it's the red blood cell that then takes the oxygen to the tissue. But you need to have a certain number of red blood cells so that your delivery of oxygen to the tissues is efficient, and it's the kidney that determines this number. Now, how does the kidney do it? Well, the kidney makes a hormone called erythropoietin. Well, then what happens? The erythropoietin goes to the bone marrow, because the bone marrow is the factory that makes your red blood cells. When you eat a bone, or you give a bone to your dog and they're eating the bone marrow is actually contains all the cellular machinery to make red blood cells. That's where blood is made. It's made inside your bones. And the bones will make a certain amount of blood, in this particular case, the red blood cells, depending on how much erythropoietin is coming to the bone. The bone marrow recognizes the erythropoietin, and when it sees it, it sends a signal to the bone marrow to make red blood cells. And patients who have kidney disease have an increasing loss of the ability to make this hormone. So not only does the kidney not regulate the blood chemistry as far as potassium and nitrogen and salt and water, as we talked about, but the kidney starts losing its ability to make erythropoietin, and the doctor has to give you the erythropoietin to keep you from getting anemic. And that's one thing we do in patients on dialysis, for example, who don't have any kidney function. We have to give them the erythropoietin artificially, or they will become anemic. What else does the kidney do? Well, the kidney controls the health of your bones because it determines the amount of calcium and phosphorus that's in your body. The kidney controls calcium because it makes the key vitamin D hormone called 125 vitamin D. When you take vitamin D tablets from the pharmacy or in a vitamin pill, that's not the active form of vitamin D. The kidney takes that vitamin D and turns it into the active form called 125 vitamin D. So when you have kidney disease, the kidney cannot make the 125 vitamin D normally. And when you take the vitamin D in your multivite or vitamin D tablets, you're not generating as much of the active form of vitamin D as is necessary. And so your skeleton gets abnormal because it doesn't have the sufficient amount of calcium in it. And the kidney also controls the amount of phosphorus, which is also important because the bones also contain phosphate. So to have a healthy skeleton, you have to have normal functioning kidneys. So when you have kidney diseases, no matter what the cause, it doesn't matter in general, you end up with a bunch of things that happen because of the loss of a lot of these functions that I was talking about. You can get water or what's called fluid overload, and you will notice swelling of your feet. That's because you have too much water in your body, and the water tends to accumulate in your feet because of gravity. Kidney disease, when it's severe, also causes nausea and a lack of appetite. That's not something you would predict. Doctors often mistake this for a problem with your stomach or your intestine, but there's nothing wrong with your stomach or intestine. It's the kidney, when it becomes abnormal, sends signals to your brain that make you feel nauseous and make you not want to eat. As I mentioned, the kidney, if it doesn't function, will prevent you from getting rid of water. So not only will your feet swell, but your blood pressure will go up. The feet swelling, you might have heard, we call that edema. Then you can get what are called electrolyte disorders. These are chemistry disorders of your blood. These symbols are chemical symbols. Na is sodium, K is potassium, Ca is calcium, Mg is magnesium, P is phosphorus. This is called bicarbonate, or what's in Arm & Hammer baking soda, the box of baking soda you have represents this. The kidney also controls this. In fact, the kidney absorbs about a box of Arm & Hammer baking soda every single day. So the kidney controls what we call these electrolytes. And when it's not working normally, you get marked abnormalities in the blood levels of these things that the doctor measures. Anemia, we talked about because the kidney makes erythropoietin. Some people with kidney disease appear to be depressed. In other words, they don't want to get out of bed. They can't sleep. They don't feel like eating. But there are subtle differences from true depression. Now, obviously, a patient with kidney disease can become depressed, like anybody can become depressed. But when kidney patients talk about some of their symptoms, doctors oftentimes misdiagnose them as being depressed when they're not. And so you have to really take a good history. And also there's tests you can do to tell whether you're really depressed or not. And oftentimes they seem like they're depressed, but they're not. They also have sleep disturbances where they stay up at night and sleep intermittently during the day. And many patients with severe kidney disease find not only do they have a loss of appetite, as I mentioned, but the food tastes. They lose the ability to have strong tastes in their mouth. And so when they eat food, that also contributes to not a lack of appetite, but just not wanting to eat. There's some patients that have a good appetite with kidney disease, but they can't really taste the food like before. So the food has to have more spices put on, other ways of making it appear more appealing. So now that we've gone over what the kidney does, let's talk about what tests we do to see if you have kidney disease or not. And the most common test is to measure what's called the creatinine in your blood. So when the creatinine is 1, you have normal kidney function. When the creatinine is 2, you have half the kidney function. And when the creatinine is 4, you have a quarter of the kidney function. That's how it works. You'll also see a test called eGFR on the lab report. That stands for estimated GFR. So you can think of it like this: when the creatinine's 1, your eGFR is 100. When your creatinine's 2, your eGFR is 50, and you have CKD stage 3. When your creatinine's 4, your eGFR is 25. You can think of it as a percent too, so that your function is 25% of normal. You still don't need dialysis yet. You only need to go on dialysis or get a kidney transplant when the function is 15% of normal, where your creatinine would be 7 or 8, something like that. So we have a big reservoir of function where we still don't need dialysis. You can go from 100% all the way down to 15, 18%, and you still don't need to be on dialysis. Now, you may not feel well. The kidney may not be doing everything it's supposed to be doing, but you still don't need dialysis treatment. Another thing we look for is urine protein. There should be no protein in the urine because if the filter that I talked about in the nephron, that first part here, is working properly, it doesn't let protein into the rest of the pipe here. But if this filter is not working properly, you will get protein actually coming through here when it shouldn't, and then ending up in the final urine, which is shown here. And the doctor in the office can test for that right away. We have these little colored sticks, and the more protein there is in the urine, the stronger the color. It's a sort of a rough approximation. The other thing is that urine that has a lot of protein has a lot of bubbles in it. That's what you're seeing here. Now, the other thing we look for is blood in the urine, because the filter here should not allow any blood to get into the rest of the pipe. There should be minimal red blood cells here, and then minimal red blood cells in the final urine. But if you see urine that looks like this, you know there's red blood cells in the urine, most likely. Now, there's gradations from what looks like nothing to what looks like more. Even though this looks normal, there still could be red blood cells here. So we also look at this urine under the microscope, and we look for red blood cells. If we see blood in the microscope, under the microscope, even though the urine looks normal, we call that microscopic hematuria. It still means that the filter is not working normally. It's letting some red blood cells through, but not enough to color the urine red. Now, sometimes we'll get a patient coming to the clinic and they'll say, "Doctor, my urine turned red yesterday. What do I do? I'm petrified." And our first question is, did you eat beets last night? Because eating beets creates a chemical that actually, it's not blood. It's a chemical that gets through the filter here and gets into the final urine, and the chemical is red. It's one of the metabolites of beets. And so that's probably, from at least a dietary reason, the most common cause of red urine. And we tell the person, "Don't worry, just wait, and it will go away after a few hours." Sometimes it can get into your stool, and you look at the toilet water and you see red there, and you think it's blood from your stool, but it's not. It's just the chemical from the beets, and that obviously goes away too. Now, if there's really red blood cells in the urine, then you've got some abnormality with the filter, and there's hundreds of different diseases of the kidney that can ruin these filters. And so, and many of them are associated not only with the urine being red from red blood cells, but too much protein gets into the urine also. Now, another problem that patients can get, especially in young women who are sexually active, they can get urinary tract infections. And we see this by looking at the urine under the microscope. These are bacteria in the urine that you should never see. And we also, like any infection, see what is growing, and we'll take a sample and put it on this agar plate here. This agar plate just has food for the bacteria, and it should look like this if there's no infection. However, if you have bacteria there, you'll start getting these little bacterial colonies growing. And that means there was bacteria that was put on the plate. And as I say, the plate should never have anything on it if you put on a solution without bacteria. And this usually takes 2 or 3 days to grow. And from this, the lab can tell exactly what the bacteria is, but patients don't want to wait 3 days. They want to know immediately. So this can be done immediately. You can look under the microscope. The problem with this is you don't know exactly what the bacteria is, and you don't know which antibiotic to use. this plate will tell you the exact bacteria and it'll tell you its antibiotic sensitivities. But as I say, it takes 3 days for this to happen. So normally, if the doctor suspects a urinary tract infection, they'll just recommend an antibiotic that will work in most people. Then they wait for this to come back to confirm that either the antibiotic was right or it's wrong. If it's wrong, they'll switch the antibiotic. Now, how does a urinary tract infection manifest clinically? Well, it tends to cause burning in the urine, and you go frequently. So you find that you're peeing a lot and that you have burning when you pee. That typically is a urinary tract infection. Now, what are other diseases that affect the kidney? Well, one of the major ones is diabetes. And if you go to any dialysis unit, half the patients are on dialysis because of diabetes. So people tend to think of diabetes as a sugar disease. Yes, it is. Your blood sugar does go up, but it also can affect multiple organs. And it does so because it destroys your blood vessels. So when you think of diabetes, yes, you can think of sugar like everybody does, but that's not what's going on as far as why it causes a problem in your body. It causes a problem because it's one of the diseases that attacks your blood vessels and can ruin them. And blood vessels obviously are important because that takes the blood all over your body to every organ. And the kidney is one of the end organ targets also. It also can affect your brain, so you can get a stroke. It can affect the blood vessels in your heart, so you can get a heart attack. But it also affects the kidney by affecting how much blood comes to the kidney. And this is what the arteries look like, not just the kidney, but anywhere you have arterial abnormalities from diabetes. The inside of the tube here starts getting all these fat deposits and blood clot. In fact, you can actually have the thing narrow down to hardly anything. And you might have heard of people who have stents put in their coronary arteries. Well, that's because the diameter here of the blood vessel is very low if they're a diabetic, and the doctor has to put a stent in to widen it back to normal. That can occur in the kidney too, and we put a stent in the renal artery. So the stenting can be in many places, but the bottom commonality is that the blood vessels are too narrow to allow that sufficient amount of blood to get to the organ. So that's one problem in diabetes. The second problem is diabetes attacks the filters that I showed you. This is one filter under the microscope, cut and cross section. And it should look like this. Each of these little holes here is like a little filter that lets the urine be created on the other side. But this is a diabetic filter. You see how it's filled up with all this junk? Well, this filter is not going to filter very well. And so what's going to happen is the patient's creatinine is going to go up, their eGFR is going to drop, and they'll have, a certain CKD stage. So the bottom line is diabetes attacks the filter and it ruins the blood vessels coming into the kidney. And as I say, if you can get rid of diabetes, you would get rid of half the dialysis patients in the world. In the United States, there's about 650,000 people on dialysis. Roughly half of them are diabetic. This is another disease of the filter. This is another way we look at the filter. We're staining it for something called IgA. IgA is one of the antibodies in your blood. And these filters have IgA attached to them. But it's very common in Southeast Asia. In fact, it's one of the most common kidney diseases. And it is a cause of blood in the urine. So if there is true blood in the urine, so let's say you have a 17-year-old and they say, usually it's preceded by a cold-like symptoms. I had a runny nose and didn't feel well. And then Monday morning I went to pee and my urine was red. Well, what we'll do is we'll take a kidney biopsy, stain it for IgA. And if we see this, they have a disease called IgA nephropathy. This is the filter. You can't even see any holes in the filter. It's all filled, not with junk like the diabetic one, but with a bunch of these blue things. These are inflammation. The filter is filled with inflammatory cells that are preventing it from working and ruining the filter so that blood can get through it into the final urine. And then again, this is just one out of the million you have in each kidney. Another problem with the kidney is that you can get kidney stones. So again, because there's calcium and phosphorus in the urine, the calcium can actually turn into a stone. And the stone can be in many places. It can be in this part of the kidney. It can be here. It can be in the final tube that comes out of the kidney. This we can see. This is a real tube. It's called a ureter. There's one coming out of each kidney into your bladder. So the urine from each kidney leaves the kidney, goes into the bladder. Well, this tube can be blocked by a kidney stone. And these are just some stones from patients. It's a real stone. If the stone blocks the pipe, the ureter coming out of the kidney, you get excruciating pain that's worse than having a baby. It's the worst pain you can feel, and it starts in your back and it travels down the front into your groin, and people are screaming, crying with pain, or they're throwing up. It makes you very nauseous, and we have to give, it's one of the situations where we give morphine to stop the pain. And then after the pain is stopped, we'll then try to figure out where the stone is, how many stones, what the best approach is. Sometimes the doctor goes in and takes the stone out physically. Sometimes they blast it with radio waves or a laser. Sometimes ultrasound can be used to pulverize the stone. So there are many ways of treating stones. Our approach is, and any doctor's approach should be, not only do you want to get rid of the current problem, but you want to figure out why the patient's making stones. And there are many diseases that make you prone to getting kidney stones. And it turns out that something that you wouldn't think about is a great way of preventing a lot of kidney stones, and that's just going on a low salt diet. A low salt diet can decrease your chance of getting a kidney stone significantly because it helps the kidney absorb calcium. When you go on a low salt diet, your calcium absorption from the kidney back into the blood increases so that the calcium doesn't come into the urine here, this brown part where you can make a stone. It doesn't allow the calcium to get into the final urine. It takes the calcium back into the blood. And so just by going on a low salt diet, you can prevent yourself from getting kidney stones. Some people have recurrent stones. It's a very common problem. And this number 15 million, it probably underrepresents the number because a lot of people might get stones. The stone can come out. They don't even know they peed out a stone. And so we'll never know about it. We only know about it when it causes a problem. Another disease which affects about 10%, 5–10% of people on dialysis is called polycystic kidney disease. It's a genetic disease and it affects a certain protein in the kidney. But what it leads to is the kidney looking really abnormal with all these blebs on the surface. And these abnormalities, these blebs that are everywhere, increase with time. And oftentimes they don't start, even though you have this from birth, they don't start till you're in your 40s or 50s. And so, and some people with polycystic kidney disease are fine their whole life. So the so-called phenotype, or which means do you have an abnormality that is expressed? Just because you have an abnormal gene doesn't mean you have a phenotype. That's true of all of medicine. So you can have a gene that's mutated or abnormal, but you're fine. And yet your sister who has the same genetic abnormality is not fine. And that's because we have 20,000 genes in our body, and the other ones can modify the abnormal ones. So you may have a bunch of other genes that prevent you from getting into trouble, whereas your sister doesn't have those other genes, and so the abnormality is expressed. So the actual abnormality, even within a given family, even though everybody has the same mutation, varies among the different family members because of the other genes that are in their DNA. And that's true of all diseases. You can have two people with the same mutation, but one has a problem, the other doesn't. And it's not that one doesn't have the mutation, they both do. It's just that other genes can modify whether you're going to get what's called a phenotype, meaning an abnormality or not. But at any rate, this problem not only creates these blebs, but the kidney tissue gets destroyed in people who have the abnormality, and it will get destroyed at different rates. Some people can have an abnormality with this at age 40 and it doesn't progress. Other people, it can progress all the way to where you get to CKD stage 5 and you're on dialysis. This is another problem that you might have heard of called lupus. It tends to occur in young women, And this is a disease where you get inflammation in many organs in your body, not only the kidney. Here's a normal filter in this patient, and look at the lupus filter, filled like the IgA nephropathy patient with all these blue things, and these are inflammation cells, totally swelling up the filter, making it larger, blocking the holes here, preventing fluid and all the things that have to go through the filter from coming out, but letting abnormal things come out like blood and protein that you shouldn't see. Lupus also affects other tissues in the body. It can affect the cheeks here. So the blood vessels under the cheeks are dilated. That's why it looks red. And they're often misdiagnosed as having been in the sun. It's called a malar rash. It's not really a rash. It's dilated blood vessels under the skin from the inflammation. They can get what's called alopecia, lose their hair. They can get inflammation in the brain, the heart, everywhere in the body, really. So it's a multi-organ problem, but the kidneys are one of the organs that gets affected. And we can get cancer in the kidney like any organ. This is a cartoon showing a cancer here in this part of the kidney. And this is a CAT scan. This is what a normal kidney looks like on CAT scans. In the back, this is the back here. That's your spine, one of your spinal bones. The kidneys are sort of back here in the back, in the lower back. That's what a normal kidney looks like. It looks like this horseshoe. And here's a kidney that clearly is not normal. It's got cancer in it. Not one of the common cancers, and it's certainly not a cause of a lot of patient death compared to like lung cancer, for instance, which is the most common reason people die of cancer, lung cancer. So as far as dialysis, there's about 650,000 people in the United States on dialysis. Every year, there's about 100,000 new patients that go from CKD stage 5 to going on to dialysis. And there's about 100,000 people every year who die who are on dialysis. So the number stays around 650,000. The 100 is worth remembering also because there's about 100,000 people waiting for a kidney transplant every year. So we have two forms of dialysis. One form was invented in the Netherlands in the 1940s in Nazi-occupied Holland, where the first dialysis procedures were performed on patients. The machines didn't look anything like this, but that technique then spread around the world till the 1950s when it became more prevalent. So hemodialysis is one technique. Patients have two needles that are in their arm. There's something in their arm that's created called a fistula, which allows the arterial blood to get into the venous blood because the blood has to come out under high pressure. And we don't want to have needles go into an artery because you'll have blood squirting across the room if something happens under high pressure. So it's put into the vein, but the pressure in the vein is increased by joining the artery to the vein. It's called a fistula. And there's an input into the arm and an output. First, the blood leaves the arm. It goes through this pump. So this pump inside the machine simply is making the blood go into this thing here. This is the meat and potatoes of the machine. This is the dialyzer. Blood goes into this thing, and then the clean blood just goes back into the patient's arm. And the machine is really doing nothing. It's just got pressure sensors and pumps. It's this thing here, the dialyzer, that's doing all the work. The way this works is that blood comes into here and then is broken down into thousands of, you can think of them as little straws. Blood goes through the center of those, and then they all rejoin. All the straws in here rejoin. So the blood's going through the center, and on the outside of those straws is a solution that we put called the dialysate. And so what happens is the chemicals that shouldn't be in the blood go through the wall of the, you can think of them like straws, even though they're not. And they let things go in and out of them. So the blood is going into the center of these straws, and on the outside is this other solution, and chemicals can leave the straw into the outside solution. And then the dirty outside solution containing the patient's chemicals just goes into a drain in the floor. And then the clean blood goes back to the patient. So it's this thing here called the dialyzer, which is doing all the work. And the patients typically come in 3 times a week, and they do this for 3.5 hours each time, either on a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday. The other kind of dialysis came to the fore in the 70s, and it's called peritoneal dialysis. There's no blood involved and there's no needles, and the patients don't come to a clinic for this. They do this at home, and they typically do it while they're sleeping. They hook themselves up at night before they go to sleep, and then they unhook in the morning, and they go about their daily chores. How this works is that the dialysate doesn't go into a dialyzer. Our special solutions don't go into the dialyzer. They go into the patient's abdomen. They don't go inside your stomach. They go into a cavity called the peritoneal cavity that normally is flat. There's nothing in it. There's no solution in it. And you can think of this as a balloon that if you put liquid into it will expand. And you can put the equivalent of about a 2-liter Coke bottle into here. You expand up the cavity. And what happens is the cells that line the cavity actually allow chemicals to go back into this cavity from your blood. So let's say the technique is to take the solution, 2 liters, which is equivalent, let's say, to a 2-liter bottle of Sprite, whatever it is, put it in here over 5 or 6 minutes. Then you let it sit for 2 hours. The chemicals that are not wanted go into this solution. And then after 2 hours, you just drain out whatever was in here. So the whole cavity here collapses down, and then you put another solution in. Let it sit for 2 hours. And this is done about 5 times during the night. It's done automatically by this little machine here, which is now very quiet. You set it all up before you go to sleep, and you get about 5 of these exchanges happening throughout the night. So 2 liters in, sits for 2 hours, comes out, next one, such that after about 5 of these, each of about 2 hours duration, you've dialyzed sufficiently. Now, a lot of people can't stay in bed for 10 hours, so you can shorten it. Maybe you do one in the evening or that kind of thing. But roughly you need about 5 of these 2-hour exchanges to keep your blood chemistry constant. And this is what we recommend to everybody. Number 1, you do it yourself. You don't have to go to the clinic. You're in control of your own health. You do this every night, not 3 times a week like hemodialysis. Sometimes we let the patient skip a day if they want a break. The other is transplant. Now, question we always get asked is, what happens when you get the transplant to your other kidneys? We leave them in. Now, we don't do the transplant as nephrologists. Transplant urologists put the kidney in. So we work very closely with our surgical colleagues. We look after the patient prior to the transplant and post-transplant. The surgeons simply put the kidney in. It's not a complicated procedure. It's one of the easiest surgical procedures. What they have to do is hook up the red artery, the blue vein, and then that tube called the ureter that goes into the bladder. Just so you know, when your brain says, I have to pee, it's because your bladder filled up to about 1/3 of a liter of fluid. There's pressure sensors in the wall of the bladder. And when those pressure sensors or stretch receptors get stimulated sufficiently, and it usually takes about 1/3 of a liter, there's nerves coming out of here that go to your brain, and your brain gets this feeling, oh, I have to pee. And when you pee, you're just emptying your bladder. Now, the kidneys are making urine 24/7. They don't make urine only when you pee, and they don't stop making urine only when you pee. They're always making urine. The kidneys don't know what the weekend is. The kidneys don't know what a vacation is. The kidneys don't know what sleeping is. 24 hours a day, they're making urine and filling up the bladder. The kidney is hooked up to a separate part of the blood vessel system here. We keep and more in the front, we keep the previous kidneys in because they may still be making erythropoietin, or to prevent you from getting anemic, or they may still be functioning a little bit. Why would we want to take them out and lose that, 10% of function that you still have. In fact, it's been shown that the more so-called residual function you have, you do better. So we never take the previous kidneys out. In the future, and there already were a couple of these this year, only external in patients who were dying. They're called xenotransplants. These are pig kidney transplants. And there were a couple this year where the family allowed the experiment to be done. The patients were going to die, and they were brain dead. They attached the kidney on the outside, not internally, and it functioned for a period of time. There was also a xenotransplant from a pig in a cardiac patient who lived a number of months before it failed. So eventually, all the rejection associated with this will be worked out. At UCLA, we're working on a totally artificial kidney that is not based on anything with cells or biology. You'll also hear people, common question is, Dr. Kurtz, do you ever think stem cells are going to end up doing anything? And my sort of common answer to that is it would be easier to make a 747 airplane out of stem cells. The kidney is much more complicated than any computer on your desk or any airplane that you fly in. It's got 50 or 60 different cell types, each of which do very complicated things. So we will never make, in my estimate, an artificial kidney out of stem cells, at least not for 100 or 200 years, unless something major is discovered in biology. So our approach here is to not go by anything biological, but to make this out of engineering components, and we've been working on this for the past 7 years. So the take-home message for this is, please look after your kidneys. Make sure you know what your creatinine is. Make sure you know what your blood pressure is. These are easy things to know. And the reason there's about 40 million people, which I didn't mention, 40 million people in the United States with some form of kidney disease. These aren't people on dialysis. They just have CKD stage 1 or 2, that sort of things, but they don't know it. In fact, 1 out of every 8 people that you meet has abnormal kidney function and doesn't know it. So when you go to a party tonight or a restaurant, look around. 1 out of 8 to 10 people has an abnormal creatinine and likely doesn't know it. And the reason is you don't feel anything. But once you start getting the problem, the kidney abnormality can progress, and you can go from CKD stage 1 to 2 to 3. So it's really important, especially for people who are 20 and older in their 20s, to get a baseline, just to know that there's nothing going on with your kidney. And then you can, every couple of years, get your creatinine. If your blood pressure is elevated, which can occur at any time in your life, take it seriously. Get a good blood pressure cuff. An Omicron cuff is quite good. They're cheap. They're $50 to $60. And know what your blood pressure is. People tend to weigh themselves. They always know their weight. But for some reason, they ignore their blood pressure, which is something very easy to measure and is equally as important as your weight. So that's one of the most important take-home messages. The other thing is, tell your friends about it. Tell your friends about getting their creatinine and blood pressure measured. Help sort of evangelize your social group to take seriously the care of their kidneys. Because if you look after your kidneys by keeping your blood pressure normal, not take pills, which I didn't mention, some of the common pills like ibuprofen or Motrin are not good for the kidney. And we have a number of patients who have chronic pain, and they take ibuprofen for the pain, let's say, back pain, whatever common pain people get it after their 50s or 60s. You can destroy your kidneys from that. And so it's very important to know, and we have patients like that who are on dialysis now who would have had normal kidneys had they not taken pain pills. And the problem is the doctors, the primary care doctors don't often think about it or follow it and don't get the creatinine measured, but it's just something important to know. Now, Tylenol is safe as far as the kidney. It's not an issue. It's the ibuprofen you don't want to take too much of. And if you have someone with chronic pain who needs 6 or 7 or 8 ibuprofens a day, you better get your kidney function assess just to make sure that there's no problem there. And I think I'll stop there, and I'd be happy to answer any questions or help any of you if you have any questions about my talk or other questions that you joined the talk for.